Hello, welcome to the Medical Licentiate Emerson channel. So today we are going to do our Osce prep cases, but specifically we are going to concentrate on the Paediatrics Osce. So this will be our number 4 series on our Paediatric Osce. Okay, so without wasting further much time, let's start. What is the problem in this child? That's the first question. What is the problem in this child? Then question 2, briefly narrate the management. Then question 3, name the blood investigation to confirm the prognostic condition. Then give the specific antidote to this condition. So those are the questions. So if you have analyzed through this question, I'm sure you can try to write, especially the problem. You can try to think of the problem that you might also be thinking of before I show you the answer. But without wasting much time, let's go with the answers. So the answers are, what is the problem in this child? So this child is having what we call organophosphate poisoning. And the rationale for this is because the child likely, of course, has organophosphate poisoning, given the symptoms of shallow respirations, altered sensorium, and sluggish reaction to light, combined with a recent exposure to pesticide on the farm. Remember, one of the examples of organophosphates are pesticides. Okay, so pesticides, of course, are examples of organophosphates. Then, question 2, briefly narrate the management. So, briefly narrate the management. So, management number 1 would be supportive care. You have to maintain the airway, breathing, secretion, and managing symptoms. For instance, if it was not mentioned. For instance, if the boy was having like increased secretion, so of course we have to suction those secretions. So that's what you mean by managing the symptoms. Then the second management point is decontamination. So you have to remove contaminated cloth and washing the skin with soap and the water. So before you even actually start doing the maintaining the air breathing secretion, actually you have to begin with the decontamination, and of course yourself you have to put on protective gown. Okay. Then management 3 is of course administration of antidotes depending on the type of pesticides. Then also have to monitor cross observation of vitals, neurological status, and cardiac function. So these are some of the brief narrate of the management principles. Okay. Then you also have to that's also question 3. Question 3 says name the blood investigation to confirm the condition itself. Okay, so question 3 reads, name the blood investigations to confirm the condition itself, the condition in one. Okay, so A, you have to do red blood cell and plasma cholinesterase levels. So this is done so in order to confirm organophosphate poisoning. Remember, organophosphates actually hinder the cholinesterase enzyme so that it stops breaking down the organophosphates, or specifically so that it stops breaking down the acetyl choline into acetyl choline. So you have to check for the levels of the plasma cholinesterase enzyme. Then the other investigation we can do is the complete blood count to evaluate signs of infection or even bleeding. Okay, that's what you need. But of course, in order to confirm the diagnosis, the plasma cholinesterase level is diagnostic. Then question 4 is saying give the specific antidote to this condition. So the answer for this question is pyridoxine, which is an oxime, and the what it does is just that it reactivates the acetylcholinesterase enzyme. But of course, you have to note that atropine is actually used to counteract the effects of the excessive acetylcholine, not really, and it's not really the antidote. So remember, there's the effects of acetylcholine. We have the nicotinic and demuscarinic effects. So the atropine is going to counteract these effects. Okay, that's what you need to understand. But the actual antidote, the one which actually reactivates the acetylcholinesterase, is pyridoxine, which is an oxime. So that's the end of question 1. Let's go to question 2. Okay, so station 2 reads, look at this picture of a 5-year-old boy and his urine. Question 1, write down one physical feature you see. Question 2 reads, list down 2 important facts you would list in your history. Question 3, what are you likely to find in urine? So of course I added this, that's the answer. Of course we're going to again go through it. Question 4, what is your most likely diagnosis? Question 5, name 2 management points in this condition. Question 6, name 2 complications associated with this condition. So I hope you have analyzed through the question, and especially what you have seen in the physical feature, and especially on the most likely diagnosis as well, because Osce is all about fast processing of information. Okay, so let's start with the physical feature we have seen. So this patient has an Asaka. Okay, why are we saying an Asaka? So rationale is that the child has generalized edema, which is of course swelling all over the body. For instance, if you have seen, there is a facial edema, there is ascites here. So and this is generalized edema, which we term as an Asaka. So that's the thing. That's why we have said it is the way it is. Okay, and then important facts in history. Number 1, we can talk about the duration of edema. How long has the child had swelling, and has it been increasing or decreasing over time? Then you also need to ask history of previous episodes of edema or urinary problems. Has the child had any previous episodes of swelling or urinary problems, such as hematuria, or which of course is blood in urine, or recurrent urinary tract infections. Then lastly, you also need to ask about the recent infections or vaccinations. So you need to ask if the child recently had any infections or any vaccines that they think that could trigger any condition. For instance, in our case, we are thinking of nephrotic syndrome. So you can ask, which vaccines do you think can trigger nephrotic syndrome? So of course, we'll be talking about the pneumococcal vaccines as well. They can of course trigger this. So that's why history taking is important in asking questions. But of course, when asking, you have to ask an open one. So let's ask you for other like immunization history. Okay, if of course this is in this boy, I have to ask immunization history. The reason why you're asking that, because we want to see if the child has been given any vaccine that can trigger nephrotic syndrome. I hope it's making sense. Then question 3, urine findings. So the answers are for urine finding. Remember on the last page we said there's protein in urine, but of course the last term does proteinuria. The reason why there's proteinuria is because specifically the presence of excess protein in the urine is actually the hallmark of nephrotic syndrome. That's the rationale. Okay. Then question 4, the answers are the most likely diagnosis. The answer is nephrotic syndrome. Why are we picking nephrotic syndrome? Because actually we are following a triad. So this condition is characterized by massive proteinuria, which of course I'm sure you have seen the frothy urine here. And apart from massive proteinuria, we have hypoalbuminemia, which is low albumin levels in the blood, and of course you have edema. Okay, that's the answer. So meaning, of course, the most likely diagnosis is just nephrotic syndrome, but we are putting rationale so that at least we explain to people why the answers are that way. Then let's go to management points. So management points, we have number one management point is you have to give corticosteroids. So it means studying corticosteroids such as prednisolone to reduce proteinuria and inflammation. Okay, but since you haven't been asked on how exactly and how we have to treat and give dosages, of course, we are going to end here. Then we are just giving out the points. Then B, dietary modifications. So we also have to implement a low sodium diet to reduce edema and promoting a balanced diet to ensure adequate nutrition, because nutrition is very important in nephrotic syndrome. Then question 6, complications associated with this condition. Number one, we have infections. The reason why people with nephrotic syndrome have infection is because they are at increased risk of infections such as pneumonia, cellulitis, due to an impaired immune function. Okay. Then B, you can also have thrombosis. Okay. Why thrombosis? Because the increased risk of thrombosis, which of course just blood clots, is due to the loss of anticoagulant proteins in your urine, which can lead to complications such as pulmonary embolism or even a stroke. Okay. Then the other condition we can talk about is acute kidney injury. So the risk of acute kidney injury due to hypovolemia, which is low blood volume, or nephrotoxic medications. So the acute kidney injury is a complication. But of course there are a lot of other complications, but I'm sure you can check out the we have a total video on nephrotic syndrome. So I'm sure that's where we can check out the other complications, and overall even the management itself has been well tackled in the tutorial video for nephrotic syndrome on our channel. So just go on pediatrics playlist and look for nephrotic syndrome, and so that you have more information actually. Okay, so let's continue. So session 3, look at this neonate. Okay, write down one striking finding. Question 2, write down one important information about the mother to help with the diagnosis and management of this baby. And question 3, what is your diagnosis? Question 4, list down 3 complications he is likely to have soon after birth. Question 5, write down one bedside test you would quickly carry out to help with the management. Okay, so after looking at this neonate, so of course I'm sure you have actually gone through the striking feature, the history, you can ask the mother, and of course the diagnosis as well as the complications and the bedside tests. So without further wasting much time, let's start. So the striking finding in this question, in this picture, is the macrosomia. So the baby is actually larger, the neonate is actually larger than the average. So this baby is larger than average. So this is termed as the macrosomia. Okay, that's the striking finding. Then important information about the mother you can ask is to ask if she has maternal diabetes. Okay, so if she has maternal diabetes. So knowing if the mother has maternal diabetes or gestational diabetes can actually help us with a diagnosis and management of the baby, as maternal diabetes is a common cause of macrosomia. So this is one important information you need to know about the mother, is that she have maternal diabetes. Okay, that's what you need to understand. Or is she just diabetic, or she just developed gestational diabetes? So this is very important information. Then question 3, what's the diagnosis? Okay, so our diagnosis is neonatal macrosomia. Okay, so of course the neonatal macrosomia, in brackets we can even add due to maternal diabetes, but of course we don't know the exact cause. But in this case, you have to also know the condition you are being asked. For instance, complication, the question 4 says complications likely to occur soon after birth, and you even have to tally this question with the maternal diabetes. That's why here we are saying neonatal macrosomia due to maternal diabetes, because if it's just neonatal macrosomia, for instance, maybe it's being caused by Beckwith-Wiedemann syndrome. then of course we can't answer this question, what complication likely to occur after birth. Okay, because it will be difficult. Hope you are getting the whole point of us putting due to maternal diabetes. But we are saying, even if you put neonatal macrosomia, you are well and right. Okay, even if you don't put the due to what. Okay, but the rationale for this is that the baby's excessive birth weight is likely due to the mother's diabetes, which can cause the fetus to produce excess insulin, leading to growth acceleration. Okay, so that's what you need to understand. So let's go to question 4. Okay, so the third question 4 says complications likely to occur soon after birth. And that complication is actually number 1 is hypoglycemia. Okay, so the rationale for that is that the baby may experience low blood glucose due to the excess insulin production. So what happens is that when the child is being born from a child with macrosomia is born from mother's diabetes. The mother, of course, since she has diabetes, the body has produced a lot of insulin just to make her cells actually at least get some insulin inside the cells, so that of course you reduce the hyperglycemia, so that it goes into the cells, since of course even if someone is having hyperglycemia, the cells are starving for energy, so the body produces a lot of insulin. So now even when the child is actually born, the child also gets some of the insulin from the mother, so the child is also born with the hyperinsulinemia, so meaning the child has a lot of insulin in the blood as well. Okay, so after the child is born, then the body will use up most of the glucose in the baby's child, and the number one thing that's going to come is the hypoglycemia. And if left untreated, the child might even actually die due to hypoglycemia. Especially if we find that when the mothers deliver a child, of course they are tired, they even sleep. So they just wake up, find the child has died. Why the child died? Then you just know. Then just if maybe after they discovered early, then they do a fasting blood sugar, then find that or a random one, find that the child is in hypoglycemia. So this is a very important complication to look out for in macrosomic babies born from diabetic mothers. Imagine having a mother with who is a G6 0 plus 5, and those children, she is a non-diabetic, and those children actually were dying in the night. Why were they dying in the night? Because actually were hypoglycemia. Now, of course, in our setup, find that the number one suspect for such a case would be the village people, meaning witchcraft, of course. But we are being shown that hypoglycemia is a very common occurrence due to excess insulin production. Okay, so let's go to the other complications. So other complication is respiratory distress. Why respiratory distress? Because the baby's large size can lead to respiratory difficulties such as respiratory distress syndrome. Then the other one can lead to birth trauma. So this one, we have to look at the baby's large size, which can also increase the risk of birth trauma such as shoulder dystocia or a brachial plexus injury. So those are some of the complications, but of course there are a lot of other complications as well. Okay, so let's go to the bedside tests. So which bedside test can we do? So we can of course do a blood glucose test. Remember that story I was talking about the G6 para 0 plus 5. Okay, hope you remember that story as well, because I've been using that story to help me remember any diabetic patient I'm dealing with, and I'm thinking of if she delivers, I'll even be putting a RBS profile or F/FBS profile. that at least we save that child. Okay, so why are we doing a blood glucose test? So we have to quickly check, quickly checking the baby's blood glucose level can actually help us identify hypoglycemia and guide management, such as administering glucose or formula. That's also what you need to understand, or even just breastfeeding itself. Okay, so station 4. Start the image below and answer the subsequent questions. So here we are going to look at the hemogram and list the abnormalities, whether they are low or high. So WBC is 24, then RBC is 4.6, HB is 7.1, MCV is 51.1, platelets are 511, and then the red cell distribution width is 24.5%. Okay, so we have looked at the hemogram. Next, the other question is saying write down 2 possible conditions that may be characterized by this hemogram. Question 3. What does this RDW results mean? Okay. Then question 4, mention 2 other investigations you would request to ascertain your diagnosis. Okay, so these are some of the questions. These are the questions that have been given. So let's start with the answers and the rationales. Okay, so abnormalities in the hemogram include: number 1, we have a high white cell count. A WBC count is high. So it's which is 24. So this one is what we call leukocytosis, which can be a sign of infection, inflammation, or leukemia. Okay. Then the other thing which is low is the HB. So the patient has the low HB, which is 7.1, which can indicate the anemia. So this one, the low HB can indicate anemia. Then the other thing which is also low is the MCV. The MCV is low, it is 51.1, which indicates microcytic anemia. Then the RDW is 24.5, which is high. Okay. So what's the rationale? What does it mean when the RDW is high? So the high degree of variation in the red blood cell size. So meaning there is actually the high degree of variation. Then let's go to the possible conditions characterized by this hemogram. So number 1, we can have iron deficiency anemia. The rationale for that is there is a microcytic anemia, there is a low HB, then there is a high RDWCV, which are consistent with iron deficiency anemia. Then the other cause or the other possible condition is chronic disease anemia, or also known as anemia of chronic disease, which can also present with microcytic anemia and derivated WBC. The other condition is thalassemia. Thalassemia, of course, you find that there is microcytic anemia, RDW, which can also be seen in thalassemia, which is of course a genetic condition affecting the hemoglobin production. Then lastly, the other possible condition is leukemia. Okay, so of course the IRBC as well is the reason why I have also put leukemia. Okay, so that's question 2. Question 3 says, what is the meaning of the RDW results? So the RDW results indicates a high degree of variation in the red blood cell size, which can be seen in iron deficiency anemia, mixed anemia, or other conditions where there is a disturbance in erythropoiesis. So meaning the RDW just shows you the red blood cell size. Okay, what's the size of a red blood cell? That's what it means. Then question 4, additional investigation to ascertain the diagnosis. Number one, we can do our ion studies. So we can do serum ion, ferritin, and transferrin saturations. Why are we doing these ion studies? We want to confirm whether someone is having iron deficiency anemia. Then we also have to do a blood smear. So why are we doing a blood smear? I want to evaluate the morphology of red blood cells and look for any specific abnormalities that may suggest a particular diagnosis. Then our third investigation is the renal function tests, such as serum creatinine, urea as well. The reason why we're doing this is to assess kidney function and rule out chronic disease as a cause of anemia. Okay. Then, lastly, but not the least, this one definitely you need to do this hemoglobin electrophoresis. Why are we doing this one? We want to diagnose thalassemia or other hemoglobinopathies that may be causing microcytic anemia. So that's why this one definitely you have to do. Okay, so that's question 4, and that's the last question on this station. Let's go to station 5. Okay, look at this picture of a 6-year-old child's mouth. So this is what we are looking at. The first question is, what is your most striking finding? And this is what I've seen most people when that they are being asked what's the most striking finding, they will be like, I can see the tongue. No, like we're talking about the pathologies. What's the most likely striking pathological finding you can see in this picture? No, you can see lips. Of course, these things you cannot see. You can see the uvula. No, that's not what we. That's not what we concentrate on. Okay, question 2 reads. So Osce, you have to chill. You don't have to rush. Okay, because if you're rushing, you are going to crash. Okay, so question 2 reads. He presents 4 weeks after treatment with fever associated with heart palpitations. What is your most likely diagnosis? Question 3, write down 4 possible clinical features you would look for to confirm your diagnosis. Question 4, what abnormality are you likely to find on ECG? Question 5, write down 2 ways of preventing this condition. So these are the conditions. I'm sure you have even seen the striking feature, which of course I'm showing you here. Okay, that's the most striking feature. So let's go to the answers. So the most striking feature we're going to find is that the tonsils are red and swollen, and they are covered in white areas of pus, and there are red spots present at the back of the mouth. Okay, those are the most striking finding we have. Then, so what is the most likely diagnosis after 4 weeks, of course, with fever and heart palpitations? So our answer is acute rheumatic fever. Okay, the rationale is that for acute rheumatic fever, this is usually a complication of untreated or inadequately treated streptococcal pharyngitis, also known as strep throat, which can lead to inflammation and damage to the heart valves. So meaning after 4 weeks of the fever and heart palpitations, the child has come with the acute rheumatic fever. Then we are being asked clinical features to confirm this diagnosis. What are the clinical features to confirm this diagnosis? So we are going to go to our criteria now. Okay, so we have a migratory polyarthritis, which of course the child is going to have joint pain and swelling that moves from one joint to another. Then there is going to be carditis, which is inflammation of the heart, which can manifest as heart palpitations, chest pain, or shortness of breath. Then you can also have subcutaneous nodules, which are just small painless lumps under the skin. Then you have erythema magnetum, which is a pink ring-shaped rash that appears on the trunk and the limbs. Okay, so usually that's that's our criteria which we use to diagnose or to confirm diagnosis of this condition. Okay, so let's move on to the next question. We have question 4, which of course will be visible in the next part. So question 4, what are the abnormality on the ECG? The abnormality on the ECG is that there's going to be a prolonged PRR interval. So there is usually a delay in the electrical conduction between the atria and the ventricles, which can be a sign of carditis or inflammation of the heart. So prolonged PRR interval. Then question 5, what are the ways to prevent rheumatic fever? So the acute rheumatic fever, since it's our diagnosis, how are we going to prevent this? So number one, so usually of course when you are studying, you're going to find that there is of course a prevention before someone gets the rheumatic fever. There is a prevention. There is so meaning there's a prevention before you get the rheumatic fever. Then if you get a rheumatic fever, there is of course treatment. Then of course after you have gotten the rheumatic fever, you also have to have another prevention for you to have rheumatic heart disease. Then again, if you have rheumatic heart disease, there is a treatment. So usually that's just what they are asking. So out of all those ways to prevent rheumatic fever, you remove the one for preventing the rheumatic heart disease. So you just now stick to the rheumatic fever, the first two, where we first prevent someone from getting it, and if they do get it, then you treat it. Those are the ways. Okay, so number one, we can have a prompt treatment of streptococcal pharyngitis with antibiotics such as penicillins or amoxicillin to prevent the development of acute rheumatic fever. Okay, then you can also do another primary prevention through improved hygiene and reduced overcrowding. We also have to reduce the spread of streptococcal infections through improved hygiene practices, and of course such as frequent hand washing and reducing overcrowding in homes and communities. So we are now preventing someone from developing the acute rheumatic fever. And that's the end for this question as well. So let's go to station E. So look at this picture with a 10 months old toddler. Okay, toddler's hand. He cried throughout night and has no history of trauma or insect bite. He is the only child. What is your most likely diagnosis? What is your most likely diagnosis? Okay, that's the first question. What is your most likely diagnosis? Then question 2, list down 2 important questions you would ask as to what is the cause of what you see. Question 3, what is your overall diagnosis? Question 4, write down 2 important investigations you would request to make your diagnosis. Question 5, list 4 management points of this condition. So I'm sure this is a very common Osce. So let's go for the answers. But I'm sure you definitely need to know the most likely diagnosis for this condition. Okay. So what is the most likely diagnosis? Of course, this is dactylitis. That's what you are seeing. Okay, you are not going to add anything else on this question. That's why I said previously, you have to read all the questions so that you know where to put which answers. Okay, so for question 1 is dactylitis. Then question 2, important questions to ask. We are going to ask if the child had any recent fever or illnesses. Why? Because we want to determine if the dactylitis is related to an underlying infection. Second question is if there is a family history of sickle cell disease or other hemoglobinopathies. Because we want to assess the risk of sickle cell dactylitis, which is a common cause of dactylitis in children. Okay, So our overall diagnosis is dactylitis secondary to sickle cell disease. Or if you want to make it sound nice, you can say sickle cell dactylitis. That's the overall diagnosis. Or this dactylitis secondary to sickle cell disease is usually our common diagnosis in our setup. Okay, though others will tell you to put VOC, which is vaso-occlusive crisis, and in brackets they specify which type of vaso-occlusive crisis. Okay, this is dactylitis, so there will be vaso-occlusive crisis in brackets dactylitis, then they put secondary to sickle cell disease. But of course you know that this is dactylitis, so if you put VOC alone, then of course that's wrong. You definitely have to indicate somewhere, somehow, say this is dactylitis or hand-foot syndrome. Okay, hope you have aid. Okay, and it has made sense. Then question 4, of course, is on the next page. So, okay, question 4 says important investigations we can do. So number 1, can do a complete blood count with differential count, where we have to assess for anemia, leukocytosis, and other signs of infection or inflammation. The other sign we can do, the other investigation we can do is the hemoglobin electrophoresis, where we have to confirm the diagnosis and there we have to confirm the diagnosis of sickle cell disease or other hemoglobinopathies. So we are done with those 2 investigations. Then question 5 is saying, what are the management points? Number management point is pain management, with of course acetaminophen or ibuprofen to reduce pain and discomfort. Then you have to do hydration. You have to give intravenous fluids. Okay, but of course, after our investigation for complete blood count, find that okay, maybe the child has severe anemia. Of course, then you have to opt for a blood transfusion. Then C, we are going to make sure the child kept home. So our number 3 management point is warmth. So you have to apply warmth to the affected area to help reduce pain and discomfort. Then D, monitoring. So you have to do a close monitoring for signs of complications such as infection or worsening anemia. So that's the end of station 6. Let's go to 7. Okay, so station 7 reads, look at this picture of a 6-year-old's neck. Question 1, what is the most striking feature? Write down 4 possible causes. List down 4 signs commonly associated with this clinical feature. Okay, 4 says he has an ascendant of recurrent of sore throat. What is the most likely cause of this feature? Okay, so those are the questions. So this again, the most striking feature is very visible there. So what is our most striking feature? There is a distended jugular vein. Okay, this distended jugular vein. Then possible causes, they want at least 4, and they are a lot. So number 1 is heart failure. Why heart failure? Because specifically the right-sided heart failure can cause jugular venous distension due to increased pressure in the superior and inferior vena cava. Okay, then other possible cause is constrictive pericarditis. Then the other cause is a superior vena cava obstruction. Then the other cause is cardiac tamponade. Then we have question 3, which was asking about signs commonly associated with jugular vein distension. What are the signs we can see if someone is having a jugular venous distension? Number 1 is hepatomegaly. Number 2, ascites. Number 3, peripheral edema. Number 4, shortness of breath. These are the signs which you can see if you find someone with a distended jugular vein. Hepatomegaly, ascites, peripheral edema, and shortness of breath. Then question 4. Question 4 is, what is the most likely cause if, of course, the child presented an antecedent of recurrent sore throat? Okay, what do you think it can be? Okay, so in short, they have a recurrent sore throat and there is a distended jugular vein there. So That diagnosis again will be rheumatic heart disease, which of course can also give you a distended jugular vein. So recurrent sore throat can be a symptom of rheumatic fever, which can lead to rheumatic heart disease and subsequent heart failure, causing jugular venous distension. Okay, that's what you need to understand. Okay, station 8, start the image below and answer the subsequent questions. 1. Write two obvious physical features on this infant's face. What is your most likely diagnosis? Write down two endocrine conditions likely to be associated with this condition. Question 4. You present with recurrent constipation. Write down one condition you should be investigated for. So this is our station E. Okay, so if the questions already are already giving for a diagnosis, we have been told to identify two physical features on the infant's face alone. Okay, endocrine condition, most like diagnosis. Okay, so obvious physical features on the patient's face is, of course, we have an slanting palpebral fissure. Then we can also have what we call a flat nasal bridge. So our most likely diagnosis on this one is Down syndrome. Then let's go to question 3, where we ask about two endocrine conditions associated with Down syndrome, or specifically they said endocrine condition associated with the condition. Okay, so this condition, which of course is Down syndrome, has endocrine conditions as well. And of course, others can ask you what respiratory conditions are associated with this condition, meaning what respiratory conditions. So of course, those are some of the things you need to know when answering Osce. Where after you answer Osce on a certain topic, you also read on that same topic rather than just going through Osce. What if they change the questions? Those are some of the things you need to ask yourself. What if they say what respiratory conditions? Okay, so let's go to endocrine conditions I've been asked. So endocrine conditions to with this condition is number 1, hypothyroidism. Number 2 is hypogonadism. Then even diabetes mellitus is actually acceptable. But of course, hypothyroidism and hypogonadism are very common. Okay, are more common than diabetes. Maybe that's what I mean actually. Then let's go to the last question, which is condition to investigate for recurrent constipation. So if this child presented with recurrent constipation, then the condition you have to investigate for is Hirschsprung's disease or congenital megacolon, as it is called now. Okay, that's some of the things we need to understand. That's the end of this station. Let's go to the last station now. So this OS series has 9 stations in total. So this will be our last station, and it reads: these two pictures belong to a 15-year-old adolescent who presented with generalized edema. Question 1, what do you see in both pictures? Question 2, what is your most likely diagnosis? Question 3, list down 4 investigations you would carry out towards the diagnosis. Question 4, write down 2 principles of management of this patient. Okay, those are the questions. Then let's start with the answers. So observation from the picture. So first up, the picture, which is of course here, there is a pepperish patch. There are pepperish patches on the hard palate. These ones, okay. Then the one which is here, the lower picture, there are rounded or oval pepperish brown papules. Okay, those are the observations we have seen. Okay, so you have to pay attention. Okay, then most likely diagnosis is a Kaposi's sarcoma case. Okay, why specifically? What is Kaposi's sarcoma? What's the description? So I added this description because we usually know Kaposi's sarcoma. Instead of just going through the investigation, we also need to understand What type is it? What causes it? So the description of Kaposi sarcoma is that it is a type of cancer that forms in the lining of blood and lymph vessels, often associated with human herpes virus type 8 (HHV8) infection, and commonly seen in immunocompromised individuals such as those with HIV/AIDS. So that's introduction. So question 3, investigations for the diagnosis. Okay, so number 1 is a biopsy. So you have to get a tissue sample from the lesions to confirm the diagnosis of Kaposi sarcoma. And I've seen another question where they asked, what are your findings in a biopsy? So meaning what type of cells do you find in Kaposi sarcoma? So this is a question I'm going to pose to you. Okay, so what after do you see in a biopsy, or what type of what do you see in the biopsy after doing after getting a tissue from a patient with Kaposi sarcoma? What feature do you want to see? So just type the answer in the comment section under the tutorial video. So that's what I'm going to assess you on. Okay, so should I trace your research on that, and you find that exactly what you see in the biopsy. Then the other investigation you can do is HIV testing, where I have to determine if the patient is HIV positive, since we said Kaposi sarcoma is commonly associated with HIV/AIDS. Then you can also do our HHV8, which is human herpes virus type 8 testing, to detect the presence of HHV8, which is associated with Kaposi sarcoma. Then you can also do our imaging studies such as the CT or MRI scans to evaluate the extent of the disease and detect any internal lesions. Okay, those are the investigations, so they are already 4. So let's move on. Okay, so this is our last question, which is saying principles of management. So this was our last question. What are the principles of management? Okay, so if the patient is HIV positive, of course you have to do antiretroviral therapy. So you have to initiate ART, which can help improve immune function and reduce the severity of the Kaposi sarcoma. That's if the HIV positive, of course. Then, for what we are seeing, these symptoms, we have to do a local therapy for symptomatic lesions. So options for these symptomatic lesions include chemotherapy, surgical excision, radiation therapy, or cryotherapy as well, to manage the painful or disfiguring lesions. So those are some of the things you need to understand. Okay, so that's the last session actually. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And don't forget to share this video to someone who is going to benefit from this. Okay, on the next tutorial, we are actually done on this one. And of course, feel free to check out the playlist on our channel for other tutorial videos, since we said this is our Osce number 4 for PIDS. Of course, we have other specialties as well, where we have Osce stations. Okay, see you next time.